Okay, so good evening, everybody. And I'm happy to see everybody, the audience, as well as the speakers. I'm sorry about the last session that didn't, the previous session wasn't able to be held or recorded because of technical issues. So we've had the opportunity to propose this session again, and I'm really glad that we have this opportunity. I'm really glad to see that there are some participants. Some of them I know had already messaged me that they couldn't join today, but I know that they will be looking for the recording. So I just want to give you a very short introduction. So this the topic today is going to be about health equity and about the application of open source and collaborative biomedical engineering project development and project design in order to promote health equity and so accelerate the SDGs, particularly those related to health. So just to give you a brief introduction on what health equity is, I'll just share my screen. I'm just figuring out the technicalities of this. Let's see. Okay. So. Yeah. Can you see my screen?
Yes.
Okay, great. So health equity basically means equal access to healthcare and equal access also to high quality technology. So it means that wherever you are in the world, whatever your background, whatever your cultural or economic cultural background or your economic means, you have the same access to good health and good technology, which is available all over the world to everybody, everywhere. That's basically what health equity means. And another phrase to describe it is also the democratization of healthcare. So that's another term that we like to use. And if you think about health equity, there are several parameters that we use to actually assess how equal healthcare is and good health is across the globe. And one of the most important is child mortality. So as you see on this graph here, child mortality actually is very different across the globe. So, you know, there are some countries in which, well, there's no data because there's very few people, let's say, but there are some countries in which we really are way higher than the SDGs call for. So the SDGs call for an end to preventable deaths of newborns and children by 2030, and we would like to reduce this to 2.5%. But as you can see, in many countries in the world, we're nowhere near that. So, you know, we're up to 20%. And so we're a long way away from achieving child mortality rates that are of the same level across the globe. And I think it's quite clear that by 2030, we possibly won't get there. And this is one of the main indicators of the fact that really there is a very different access across the globe, very different requirements as well across the globe. So if we look at this slide, I think it really is very, very interesting because what it shows us is an operating theatre in the 1920s. So this is the classic operating theatre during the First World War, for instance, in which you have a couple of doctors, a nurse, and a very simple bed with a patient in there. And it's very, very spare, as you can see, very simple lighting and not a lot of instrumentation. Going to the slide, going to the the right side of the slide, this is an operating theatre of this century. And what you can see here is a nurse and a doctor, and everything else is medical equipment. So it's really, really heavily reliant on modern technology. So current hospital beds, particularly in emergency or in other very critical situations of healthcare, we really rely on advanced technology. And this technology is basically technology that is developed by biomedical engineers. So what I'm going to stress here, and what I'm going to try and address, and when we speak in the panel as well, is the importance of biomedical technology, and therefore the importance of biomedical engineers in providing quality healthcare. I think this aspect is actually not regarded as important as having a large number of doctors and a large number of nurses in the healthcare scenario. And this aspect is that which may help to address the problem of health equity, particularly the problem of access to quality technology across the globe. So just to stress this fact, here are some data on the state of biomedical engineers in Europe in 2017. So this is data from the World Health Organization. Basically, the World Health Organization sent a survey to different countries, all the member countries, asking them to do a census of biomedical engineers in each country. And these are the data that came back from Europe. So the country with the largest number of biomedical engineers is Italy, with 8,477. And then if you look across here, you can see that many of the countries have very, very few. So this light blue color means that the countries reported about one biomedical engineer in the country. Similarly, in Africa, the data was pretty sparse. Some countries didn't reply. So when you have this light blue color across these countries here, for instance, Tanzania had very few, 20. Angola, for instance, very few. Egypt, 1,000. That was the country that had the most. So numbers are really, really low across the globe. And this is the total number of biomedical engineers. So there's a scarcity of engineers, and there's a scarcity, therefore, of people with the expertise to actually bring equipment, bring medical technology to people in across the globe. If you compare this with the number of doctors, I think the data are actually quite alarmingly different and possibly worrying. So this is the number of medical doctors per 1,000 people in 2019. In some countries, you have 10 doctors per 1,000 people. And these numbers are much, much higher than the biomedical engineers. So I'm just going to the internet data because it's easier to look at. It's much more interactive. These are biomedical engineers per 10,000 of the population. Okay, so for instance, 0.06 per 10,000 in Libya. So that is just going to be my pitch here, the fact that we really, really need to work on valorizing the role of biomedical engineers and valorizing the role of medical technology in bringing about health equity. How we're going to do this is something that we're going to discuss within the panel here today. But before we do that, what I'd like to do is to introduce our speakers here. So I'll stop sharing my screen, and we'll go around the speakers, and they can briefly introduce themselves, and then we can discuss the question of health equity, the problems, and possible solutions. So we'll start off with Victor Conde. So Victor Conde, can you turn on your screen and your mic?
Yes, I'm here.
Victor, can you introduce yourself briefly?
Yes, please. My name is Victor Konde. I work with the United Nations Economic Commission for Africa in Addis Ababa, Ethiopia. I'm currently actually in Finland, so that's why I'm possibly dressed up like this. Yeah, we've been working together on biomedical engineering issues, I think, for maybe over a decade now. Thank you.
Thank you, Victor. Okay, next, may I ask Daniel? Daniel, can you introduce yourself briefly to the audience?
Yes. Yeah, thank you so much, Ati. I hope you can hear me well.
Yeah.
Yeah, I am Twine Daniel. I'm a medical doctor. I'm a medical epidemiologist and a global health researcher. I've been working with Doctors Without Boundaries in Uganda as a researcher for 14 years. And I'm the current chair of the African Biomedical Engineering Consortium. So glad to be here.
Okay, thanks, Daniel. Next, I'll ask Philippa. Philippa, can you briefly introduce yourself?
Hello, everyone. I'm Philippa Makobore. I'm currently a graduate student, PhD student at the University of Calgary, working on nucleic acid assays and diagnostic platforms. My previous work was with the Uganda Industrial Research Institute, where I interacted with a lot of the people on the panel. And I worked on developing non-invasive medical devices that are appropriate and affordable for low resource settings. And it's a pleasure to be here.
Thanks, Philippa. So Elizabeth, may I ask you to present yourself?
Yes, I'm Elizabeth Johansson. I'm the founder of Spark Health Design, and I'm adjunct faculty with Olin College of Engineering in Massachusetts, USA. Spark Health Design is a collaborative international team that uses human-centered design and usability engineering to develop world-class technologies for better outcomes globally. Our focus is medical devices, diagnostics, and digital health tools. And at Olin College of Engineering, I'm part of the Olin and Babson College's Affordable Design and Entrepreneurship program, where students collaborate with communities around the world to address challenges of poverty. And the program aims to create solutions with people and to democratize opportunity. So it's great to see all of you here. Thank you for inviting me to this panel.
Great, thanks, Elizabeth. Carmelo, can I ask you to introduce yourself?
Yes. I'm Carmelo De Maria. I'm in biomedical engineering, and I'm a researcher in biomedical engineering at the University of Pisa, where I'm working on application on additive manufacturing technologies, in general rapid prototyping for design affordable medical devices. I've been working with many people in this room designing open source medical devices that we will discuss later on.
Thank you. And Andres, can you introduce yourself, please?
Hello, I am Andrés Díaz Lantada from the Technical University of Madrid. I work as professor of mechanical engineering, and I am running a product development laboratory there and member of the Ubora team since already 5 years. So really happy to be here. Okay,
thank you, Andres. I haven't introduced myself. But I think my bio is available on the platform for this summit. But my name is Arti Aluwalia, and I'm also a biomedical engineer, and I work at the University of Pisa. And together with some of the members, most of the members of our panel here, we developed a biomedical engineering platform called Ubora, which we will introduce to you and perhaps propose as a tool for health equity. Not all of us are engineers, though. Daniel, for instance, is a doctor, a clinician. Victor is a policymaker, I would say. I would define him more as a policymaker. And he's actually spearheaded biomedical engineering education across Africa, and he basically founded or helped found the African Biomedical Engineering Consortium, which Daniel is the current head of. So Victor, can you explain your reasoning behind pushing biomedical engineering education in Africa and your vision of the connection between health and wealth, because that's basically UNECA's mission, isn't it? Promoting wealth, innovation, and thereby also health.
Well, thank you very much for that. Well, maybe we should just going back a little bit. A couple of years before we started the work on biomedical engineering, we actually looked at engineering in general, which was the idea that if you can actually kind of like push engineering forward, you can push a lot of other fields forward. Whether you are looking at, I don't know, construction of bridges, roads, so you actually even if you look at agriculture. And after that, I think we kind of looked at how do we were looking at pharmaceuticals and wondering the continent trains so many people in life sciences, in biochemistry and other fields and pharmacy, but actually we have no one designing equipment that you need in industry. And after a while, I think we can go to one area where we decided, why don't we start with biomedical engineering? Actually, that was a suggestion from a colleague in Boston University. We worked with him for quite a while, and with him, we started working on the curriculum. And there are basically two main reasons. On one hand, if we can have healthy people, then you can generate wealth. At the same time, of course, I think Africa is spending so much money importing most of its medical devices. I think almost 99% of African medical devices in African hospitals are imported or donated from somewhere outside the continent. And our biggest problem is ability to maintain and everything else. So on one side, that was important that we build up the skills base. At the same time, of course, you would also want us to build our own medical devices, at least for our own environment, the one that meet our unique needs. You know, we don't have kind of like the quality of energy systems you find that are stable in Europe and the US and others. And so we needed devices either that are simple to use, whether by our nurses or doctors, like I think Daniel here. His hospital, I'm guessing, is not like I went here to a little place to look at my eyes, and there are so many equipment. And I think after 30 minutes of looking at them, I felt harassed. In Africa, when I do it, it takes like 5 minutes and we are done. So in a way, that's why on one side, you could build up a skills base, but you also want to promote innovation, and you also want to promote entrepreneurship. And that is why when we designed the biomedical engineering initiative, we included all these other aspects. So issues to do with curriculum design, which basically builds up skills. At the same time, you would want to promote, for example, students and researchers to come up with new medical devices. And you would also want to push them to acquire, for example, entrepreneurial skills and entrepreneurial mindsets, because we're also aware that we don't have enough jobs for the young people that will come out. So some of them may have to create the jobs. So it is, so that perhaps is really one of the two major drivers. But also there is a personal aspect to it. I think we talked about it in the early days. I grew up in a rural community, but in my rural community, there was a fantastic hospital. Actually, we used to get, I don't know, the flying doctor brought patients there again and again. And when I grew up, I was wondering, how can you be in such a rural area and you get, I don't know, patients flown in from the city into a village? And meanwhile, you can actually train people in the rural community to take up some of these technical skills. Oh, as soon as I realized you can actually teach one skill and they specialize in it and they can maintain the equipment and things like that. So basically that's one other thing we thought, why don't we get our students actually to go out in society, look at the problem they see and see what they can fix during their holidays. At the same time, how can they build up, I think, their own skills base. So in a way, that kind of like how we looked at it, that if you push engineering, you may actually get people to, I think you push healthcare too. The other final bit was actually on gender. I think that was an argument that was pushed, taught to me by someone else who comes from the engineering, who said, okay, if you're gonna want women to come to engineering, you should do biomedical engineering. So we're like, okay, then that field wins. So in a way, we all have the feeling that if we ran biomedical engineering, we get more female students to engineering. If they came to engineering, in the end, they may like maybe mechanical, civil, electrical, whatever else in engineering. But we need to get them there first. And if biomedical engineering can help us get female students to engineering, that's a fantastic thing. Not to mention, I think there's nothing wrong with having mothers that are biomedical engineers anyway. So in a way, kind of like we're trying to kill so many birds with one stone. And that's how we kind of looked at it. And one of the reasons we pushed it for so long.
Okay, great. Thanks a lot. Yeah, so you mentioned the rural areas. You know, I think that's a particular, particular focus for bringing the technology to rural areas and ensuring that the technology that is bought is actually the technology that's needed. So Daniel, I think you probably have a lot of experience in this field. What do you think we can do as engineers and doctors as well to better understand what the needs are and therefore to actually address them without bringing in technology that is actually never going to be used and so basically just sitting there useless? How can we help understand better needs in rural areas?
Thank you so much, Ati, and that's a very important question because I mean there's need for alignment between development and need. So when you ask that question, it also reminds me of the time when I was in medical school in Mbara University of Science and Technology here in Uganda, and were given chest X-rays to read as medical students. And there was a common saying that the eyes sees what they know, and which I think has an element of truth. So I feel that one of the ways to identify the needs that need to be addressed by medical engineers is to accelerate the effort to build this expertise and engagement of biomedical engineers and innovators into the health system. We know that as a doctor can identify a disease in a patient just by looking at them, we expect that biomedical engineers should be able to identify some infrastructure gaps when they get exposed to the health system. And I also think that, we have to support the education of biomedical engineers and increase their numbers, as you have shown in the intro, that the numbers are still few to be able to meet that kind of demand, starting from identification and providing solutions. There is also something I've noted that, within the education of the biomedical engineers, it's important not to just give them industrial exposure, but also they should be exposed to the hospitals. They should be attached to hospitals right from their training, so that they develop an early, knowledge of what is going on and the challenges within the system. So that's something that really I feel that can be done to be able to identify those needs. The second aspect that we can look at is what I call trained eyes. And this is the role of the universities to generate graduates, especially those who are doing science, technology, and engineering and innovation, kind of students who have a skilled eye to identify problems and create innovations that can address societal health needs. And in this, I mean, there is a way education is done, but I think we need to encourage and stimulate analytical and problem-solving mindset during the training of these students. And I'm reminded, as an example, when I was doing my medical school some years ago, during our 4th year training, we would be sent out into the community and attached to the health facilities. And part of the purpose was to, of this community placement is to diagnose the community, assess challenges and gaps in the health system, and give some recommendations with regard to what interventions could be implemented. And I feel that's something that could be included in the training of biomedical engineers, and they could be able to identify quite a lot of challenges. Another important element is the engagement of communities, community engagement. The communities are the beneficiaries, but also key informants and partners in health system improvement. So strengthening community engagement strategies or practices is really key. Where many countries in Africa, and I will talk about Uganda, they have been able to develop a community engagement guideline that would guide all research in the country, and I am part of the national team. But the purpose of this is to make sure that any research and development is informed by a good knowledge of the community needs, but also engaging the community as players, different stakeholders as players. And this helps to inform researchers on what the real needs are. We can't rule out the need for formative research. Formative research is another area that consciously we do research and target certain stakeholders within the health system to try to hear from them what might be the challenges they are facing as they implement the health services. And my second last point is on auditing and leveraging the health system experiences as a consequence of unexpected emergent health conditions. We have just been in COVID-19 pandemic. It caught every health system, whether in low-income countries or high-income countries, as a surprise. And you could imagine how that goes down the tire of the health system organization, even in the low resource settings. And if we can audit the challenges experienced by the health facilities amid such an unexpected pandemic, clearly it can bring to the table what challenges are in the health system. I could just briefly mention that, there was a very big demand suddenly for masks, almost for the whole globe, young and old, and suddenly biomedical engineering came to the front, the need for biomedical engineering. There was need for oxygen concentrators, mechanical ventilators, intensive care unit equipment, rapid diagnostics, and all these things brought to the front the gaps and the challenges that were in the health system, and can still, if we audit them, we can be able to know a lot we need to deal with. And the last one, last but not least, maybe the last I can say today is we also have to improve use of routine health system data. Health system data, which, this data is collected routinely in the health facilities, could be a very good indicator of what's going on. But certainly there is quite some amount of work to do before we can use such data, which includes health management information systems. And I know health information technology is one of the subspecialty of biomedical engineering. But this is a very key area that could allow us to quickly know what's going on in the health facilities and the problems they face. Yeah.
Okay, great. Thank you, Daniel. There's lots of food for thought in that. I'm wondering, Filipa, if you could bring in your side, because you are an engineer and you've actually developed a lot of technology, possibly addressing and utilizing many of the points that Daniel pulled out, seeing with your eyes, for instance. I think that's really important, being there, knowing what their needs are. So can you tell us something about your own experience as a technologist and the group leader in Uganda, addressing rural healthcare problems, or even problems in the cities?
Sure. So I think as an engineer, the first thought would be, okay, what can we create with all the relevant features that we think clinicians need and we think will be sustainable? But I quickly realized that that perspective was not going to work. And we needed to take a step back and to understand things from the perspective of the clinician. I would say also working in multidisciplinary teams. So we did involve a couple of industrial designers in our medical device development. I think that was very insightful as well, because they had also a totally different way of approaching problems. So I'd say kind of relearning the way that you tackle problems. Thinking about, what are the actual pain points, the gaps that clinicians face, on a day-to-day basis, and also with the tools that they're using. So we also realized that a lot of these settings are quite complex in terms of the challenges they have. Sometimes it's not enough to create a new device and then insert that in a system that is already broken, that may not be able to maintain that particular intervention. So we also had to think about systems around how that device can be sustained within the hospital. So thinking about maintenance, calibration, ease of accessing spare parts, biomedical technicians that are at the hospitals, would it be easy for them to maintain? What is the triage process like when something fails in a ward? When a nurse has a challenge, how is she able to escalate that so that that device can be maintained? So it was a couple of things that we looked at. Obviously, the device itself was very important in terms of the design for the context. So understanding what constraints we had to deal with. So access to power supply, clean water, the ease of use. So there are a number of different aspects that we looked at for the product itself, but then we also looked at it from the system level.
All right. Yeah, thanks. That's really interesting. So the fact that it's important to have a multidisciplinary team and to go out there and collaborate with them is obviously plays an important role. And Elizabeth, I think you also have some experience in collaborative design. One of the things I wanted to ask you was, as you work in the US, but you've developed a lot of technology for low middle income countries. What do you think is the role of collaboration and attention to local needs in the development of the devices that you've proposed? And particularly a thing that concerns me, which I think I've mentioned to you, is having the ability to not push the technology that we think is best, but the technology that actually works best in the context, which is also something that Philippa mentioned.
Yeah, thank you for the question. And I think some of my remarks will underscore how important the previous speaker's comments are on training biomedical engineers in low middle income countries to also design for the context they're familiar with and co-located with. So, what Spark Health Design does is really put international teams together in order to effectively redesign technology that's usually already been designed before. And it was really founded around the idea and the recognition that most of the med tech out there has been designed from a location of a high resource setting, and usually with the high resource setting and the people and the training and those sorts of assumptions in mind, and doesn't always include the thought of the differences in a setting in a low or middle income country. So Spark Health Design, we've ended up being a kind of go-between between experts who are in various low middle income countries who have clinical expertise, have engineering expertise, who understand the culture and the local context, and working with them to design studies that help manufacturers then understand how to design devices that better work for those settings. So one good example is a recent collaboration between Spark Health Design, Oxygen for Life initiative in Nigeria, and the Center for Public Health and Development in Kenya. Under the Oxygen CoLab, we collaborated on investigating oxygen concentrators, a technology that's existed for quite a while, but was originally designed really for the home setting in a high resource environment. And since then, there have been some tweaks, but mainly this technology, which was really designed for a patient to sit right next to and use all day long in a place that usually didn't have extreme temperatures, that often had air conditioning. That technology has found some way to provide benefit also in under-resourced settings, but often the context is so different. So often the temperatures are different, there's more dust. The number of people using it is different. So instead of one person operating it and sitting next to it all day, it's a variety of different healthcare staff members who need to interact with it on a rotating basis. Not only that, in many settings, there are a variety of different medical equipment from different brands that have been brought into the healthcare facility, which is honestly different even than a healthcare context in a high resource country, where often a hospital will make a contract with an entity such as Siemens or Philips, and they'll have devices of a fairly uniform user interface. So the environment for people to be able to use devices correctly is really, really challenging, especially because the devices haven't really been designed for that setting. So in this particular study, just as an example, Oxygen for Life Initiative and Center for Public Health and Development found that even existing oxygen concentrator user interfaces, most nurses who've been using them actually don't understand the warning light. And that's even in the face of many training programs that have taken place, et cetera. And so simple things, we found simple things like the patient sitting on the tube and it's blocked. And so it leads to the warning light. Because it's just this single warning light that was designed in a wealthy context where the person can just get on the phone and say, I've got a warning light, I don't know what it is, can you help? In a context where there really aren't many biomedical engineers to call for help, nurses say, I'm probably supposed to call someone, but there's no one available and I don't know how to troubleshoot this. So I'm going to put this device aside and we can't use it for oxygen therapy anymore. So, we're really seeing that the lack of design for the context really leads to devices that have been put in place and could work and could potentially provide a lot of benefit and save a lot of lives, end up really falling short of the health outcomes that they could deliver.
Yeah, that's a good point. Thanks, Elizabeth. I'm going to pose a question to Carmelo about biomedical device design, and in particular, the systems that are redesigned, so technology that is known and then redesigned, as well as new technology. There has to be an attention to safety, and I think you're quite an expert in that, Carmelo. But I know you're also an advocate of open source biomedical design. So can you explain how collaborative and therefore open design can incorporate safety, can incorporate medical device regulations and standards, and why you think open source technology could be the way towards accelerating health equity?
Yes, thanks for the question. It's like very important question, and part of these points have been already pointed out by Elizabeth, Philippa, and also Daniel. So, I mean, a medical device should be, or have to be safe and effective. And when people used to discuss about safety by design, means that you have to take into account safety since the beginning of the project and not arrive later attaching patches. And the way you can reach safety is to take into account the human factor, the environment in which the device is going to be used effectively, I mean, on the ground, on the field. So sharing information regarding results of the device, sharing information regarding also failure mode, sharing the results about statistics, sharing the results, sharing also the instruction for use, is the fastest way to avoid future mistakes. So sharing means that you can provide in an open source format the way the design is built and can be maintained for during its entire life. So this brings to the concept of open source medical device. This is not simple sharing these tools or the instruction or essentially the technical instruction on how to build the device, but also explain how to build this in a specific environment. Why? So why and how this can improve the health equity and the access. Think about, for example, the recent COVID pandemic. I mean, we discovered in, let's say, in high-income countries, the effect of shortage of medical device, the effect of lack of spare parts, the effect of lack of industries able to react to the shortage. There was no one company able to start a production line in a few moments. Think about instead the opportunity to have a repository where the instruction for building a new oxygen concentrator, or think about personal protective equipment that are very close to medical device. Think about having a repository such this. This can essentially improve the safety of the device that will be put into the market. Instead, we had a plethora of devices were not safe, not effective, or they never reached the market just because, I mean, it's a long process. So sharing can be a key. It's important also to note that sharing can also facilitate innovation. Why? Because, of course, putting a new device on the market is very expensive. It can take several years. And many people are afraid that sharing information, sharing details on the device can stop their market replication. Instead, what we have seen also during the pandemic in Italy, for example, if you are able to go and think about the entire value chain, if you make like a collaboration between different stakeholders, from hospital that requested a specific device, people that were selling raw materials, people that were doing a small step in the whole value chain, all of them collaborated in a specific small project like face mask. And then we were able to go into the market without any huge delay that is normal when you are doing everything by yourself. So think about open innovation. This is probably the key to promote health equity. So the problem that we can have in sharing device is vetting of information. So vetting, so deciding what is good and what is dead at that ends is really difficult and time consuming. If you have time, just Google like open source ventilators, you can find a list of more than 150 different projects. All of them were good, but a different level of completeness. So this vetting of information is very difficult. So the idea, if you can have a repository, a sort of Wikipedia of medical device, this can, I mean, reduce the gap between good ideas and the market or the patients, the set of them. This is essentially what Eubora try to do. And Eubora is a tool. I mean, It's a tool that probably we have time to discover or to discuss later, but essentially, if we bring all the communities of biomedical engineering working toward this goal, each one doing a small step, probably we can have impact on healthcare.
Oh, thanks. Yeah, no, I think that's a really interesting concept, the open and sharing of blueprints, of designs, but also of, you know, failures as well as successes. Yeah, that's really a very, very important point. I'm going to ask, he's gone though, I can't see him. Oh, there you are, Andres. Andres, something that we mentioned, right? The lack of biomedical engineers, that's clear. And, you know, it's the data are there for everyone to see. And it seems to be that what we need here is just education, education, education for engineers. But, you know, the classic education a biomedical engineer has, at least in Europe, or even I think in other developed countries, is very focused on the newest technology and maybe very theoretical. So, you know, new paradigms for education, I think are needed. And I think you're an expert on that. What can you tell us about the new paradigms that are coming up and your experience in education for BME?
Thank you, Arti. I will try to provide like a short introduction or a personal perspective. So, of course, Sustainable Development Goal number 3 on good health and well-being is fundamental. But for me, perhaps the one Sustainable Development Goal that is really foundational for all others is number 4, quality education. And I think through quality education, many of the Sustainable Development Goals can be achieved, including good health and well-being. Many kinds of engineers can contribute to this, but of course we will focus on biomedical engineering. I would like to put as example this transformation that European universities have lived in the last decades. Just after the signature of the Bologna Declaration, the ministers of European Union, the ministers of education proposed to modify how universities were training students, were delivering education. And the idea was making higher education student-centered, no? So students at the center of higher education, not only master classes, let's say, with a professor there and all the students looking at the professor, but really with students in the center. And this has led to vast incorporation of problem-based, challenge-based, project-based methodologies in which mainly students, teams of students, together with the professors, collaborate in the solving of real-life problems. So trying to reach a more applied engineering education. And I think this is fundamental in biomedical engineering as well. So one of the models that is very popular now, promoted through an international community, is the CDIO model, this conceive, design, implement, and operate, which is a kind of holistic approach to project-based learning. So teams of students in this model detect a need and try to live through the whole development process. So starting from the conceptual design, designing a solution, implementing it through the rapid prototyping, let's say, reaching to an operation in which they can test the prototype. In biomedical engineering, the implementation of CDIO experiences, of these holistic project-based learning experiences, is perhaps more challenging. As Carmelo was mentioning, the devices not only have to be effective, but fundamental is safety. And something also very necessary is co-creation with end users, with all the stakeholders involved in the complete development cycle, as well as the detection of relevant medical needs. So this makes the conceptual part of this CDIO cycle applied to biomedical engineering perhaps more challenging, but also more enjoyable, I would say. In our experience with students, they were at the beginning, when we were implementing this kind of project-based learning for biomedical engineering 10 years ago, let's say, they were always saying, we want to design, and they wanted to go into the computer and use computer-aided design, the 3D printers, design and prototype, and so on. But through the incorporation of UBORA to this CDIO, to this, let's say, UBORA-empowered CDIO model, we have learned many things for making our biomedical engineering courses much more powerful, let's say, much more impactful. Through the incorporation of the UBORA model, we have focused more on this medical need identification, the incorporation of standards and regulations from the very beginning. You know that in UBORA, we are using the new medical device regulation from 2017 745, no, as a reference for the projects, and then students follow like a guided process through which they reach a technical dossier, which would be the documentation with which they could start interacting with a notified body for approaching commercialization. So this is very valuable and fundamental, not only focus on the design and the prototyping, but document the medical device and the medical device development process in a methodical way, follow relevant standards, which many of them are harmonized or used across many countries. And this focus on standards and regulations was very difficult to incorporate at the beginning for us in the courses. But through this guided tool that UBORA incorporates, UBORA guides the medical device designers through this process and also advises which kind of standards they should apply. So this incorporation has been fundamental for improving our courses. I would say now students are also dealing with the medical device regulation, looking at the standards for the designs, and this makes the design process more straightforward and safer. So for some students, at the beginning they were thinking, why should I focus on regulations and standards and so on? But afterwards they understand its relevance and the fundamental part of documenting, because in the end, as engineers, huge part of our career is devoted to documenting what we are developing. Of course, to communicating it. UBORA, for example, as a communication, as a dissemination tool is great because it may be that some of the devices developed within educational activities do not reach the final patients. This is possibly due to temporal restrictions, economic issues, but if they are, for example, developed with the support of UBORA, this sort of, let's say, Wikipedia of medical devices, but it is much more than that, because UBORA guides the designers to apply a common medical device development framework. So all students following this methodology, they share their designs, they share their documentation, and these can be case studies that can be used worldwide by other universities. For example, in Madrid, we are using some of the devices developed by Carmelo or by Filipa as case studies for improving our lessons. And this is possible because the documentation is there in UBORA. And I hope some of the universities will use our case studies in this way. As you know, there are a couple of things that grow when they are shared. One is friendship. Friendship grows by sharing. The other one is knowledge. So the important thing of sharing is that through sharing, education will also improve. We will achieve these cohorts of biomedical engineers worldwide also trained with a similar scheme, so that they can interact with each other in an easier way for jointly solving worldwide problems. Let's say that would be the key, I think.
Great, thank you very much. Very passionate. I'm going to pass to Carmelo, and I think we need to be brief now and start wrapping up. So, Carmelo, Andres has described very briefly Ubora, but if you could be even briefer and explain what it is to some of the audience who maybe haven't come across it, just what it does, how you might be able to explore it and use it.
Oh, so for sure. So Ubora is a virtual platform for co-design and share open source medical devices. Starting from a clinical need, there is a session where you can express your need and transform this into design specification and try to, through a project management tool, to reach a device, or at least the design of a prototype of a medical device. In this way, following all the steps inspired by relevant standards such as the 13485, you are sure that if properly implemented, that prototype, that device, will be safe and effective. The structure of this platform that you can find online, of course, and you can register and you can create your own project and share with your colleague, has been designed through a 2.5 years project involving relevant stakeholders and designers, and promoting also the design of relevant devices. What's the uniqueness of this platform and why, a designer should use Ubora? Andres already explained many features. The important part is that the platform has a general framework in which you can find the relevant question or the relevant point to be sure that the device is safe and effective. Only if you respect them, it's good to share and put to share the device and say, okay, this is safe and effective, so please use this design instead of others. Last point that is really important for us at the moment, the platform that was promoted by European Union is managed by the Ubora Association that's newly created, and in the coming weeks we will start our, let's say, campaign for promoting the association of new people who want to jump in. In the meantime, you are always welcome to make a profile on the platform and start to use it both for teaching and of course for design.
Okay, thank you very much, Carmelo. We've also heard a lot about ABEC, so the African Biomedical Engineering Consortium. And again, briefly, Daniel, you've set it up and you're one of the founders. Can you tell the participants briefly about it?
Yeah, thank you so much, Ati. And certainly, as you said, we cannot understate that the need for human resources, especially in biomedical engineering, is key in accelerating innovation and design. And this is exactly what was appreciated at the beginning of the African Biomedical Engineering Consortium, at least by the United Nations Economic Commission of Africa and the universities across Africa and the partner universities in Europe. So we knew that this was one way of accelerating the health system improvements, but also the Africa's economy. So the African Biomedical Engineering Consortium was set up by universities and partners from industry, but also both African, but also with some support from experienced kind of institutions like University of Pisa. So they set up this consortium so as to steer and accelerate the building of biomedical engineering expertise to improve healthcare in Africa. So I could say that at the moment, since its conception in 2012, which is exactly a decade ago, we've been able to have a membership of almost 20 universities, African universities, and a good partnership really from even non-African institutions. And what really informed the formation of this consortium was the observed limited number of basic medical devices, as members have mentioned, and also the lack of the expertise to maintain them or to guide procurement, which all of them lead to financial loss really in the African context, and also the lack of skills to install, maintain, and manage or upgrade equipment in these settings. So in brief, the approach of ABEC in addressing these gaps is three-pronged. One is building the needed human capital. We appreciate that we have to build this human capital on the African continent. And two, we appreciate that we have to spearhead the development of an open source resource sharing platform. That was really foundational for ABEC and something that Ubora really took on and made it really alive. And also nurture entrepreneurial and innovative skills. And we do this through summer schools. We have implemented almost 9 innovator summer schools where there's been acceleration of innovation, increasing awareness about biomedical engineering, and also stimulating really interest in this discipline. And this has benefited really hundreds of students and lecturers, but also institutions which have been involved. Through this consortium, we've set very strong collaborations across universities, which help to even further this agenda. And we developed generic curriculum for biomedical engineering, and many universities which were not having this discipline have been able to implement it. And also finally, the spin-offs like African Biomedical Engineering Mobility Project funded by the European Union. Again, it was set up by some of the members of ABEC and with a primary goal of promoting, again, biomedical engineering capacity in Africa, which has given almost 43 students and lecturers an opportunity to have masters and PhDs and to engage in staff mobilities. So that's really what I can say about ABEC, and we are really open to collaboration with other like-minded institutions.
Yeah, great. So ABEC, you can find that on the internet if you're interested. Thanks a lot, Daniel. Yeah, I think we've done a lot of work and we've got a long way to go, but moving together is the thing to do, clearly. Yeah, so Philippa, you have used, you're a member of ABEC and you've used Ubora as a platform as well. There's obviously room for improvement, right? And I think you're also working on that in your PhD. So what do you think can be implemented, very briefly again, or improved in open source platforms and just in general in the community that we're working for and with?
Yeah, I think I've been caught off guard. I haven't really reflected on some of the changes that can be made, but definitely a few come to mind. I think the platform, I would say, predominantly has a lot of engineering collaborators. I would say if we can maybe engage more clinicians, people from other disciplines, I think that would be extremely beneficial. I know it has two features. The one feature for the actual development of the medical device with all the work packages, I'd say, which is a fairly technical process. But I know that there's the other side where there's supposed to be more or less a forum where people can be match made, and there's a discussion on clinical needs, and those clinical needs can also be posted to the forum. So I'd say maybe even including resources, additional resources, let's say for the community, maybe having more discussion forums with maybe targeted thematic areas, maybe even including a few challenges on maybe students could win small prizes for maybe presenting some clinical needs that they've uncovered. But those are just a few suggestions that come to mind. But I feel in terms of the technical side, the platform is very comprehensive because it gets students and users to think about the entire, I'd say, cycle of developing a medical device, most importantly, making sure that medical device standards are aligned, they've assessed risk, and then also even thinking about things like shelf life and replacement of parts and who the context with which they could be used, so who the users would be and what maintenance requirements look like. So I think that part is very comprehensive, but those are the few thoughts that come to mind.
Okay, yeah, so multidisciplinarity is key, I think, for advancement in any field. I think I'm a firm believer of multidisciplinary education as well. I think people ought to carry bags with knowledge, that pertains to engineering as well as biology, medicine. There is a question that I think is important that hasn't been addressed. We've been talking about innovation and redesigning old technology, as well as open source devices. Elizabeth, you worked on this for quite a while, and what's your own experience about the issue or the conflict between intellectual property and the protection that many companies give to their devices with respect to the open source philosophy?
Yeah, it's a big question, right? Because so many medical devices and so many companies have created their wealth around having IP, having IP around certain advantages in design in their device that other companies can't copy. So what does it mean then to create an open source device, and how can it come to market? So is that necessary to essentially have that IP and keep that kind of locked away in order to get the investment needed to get something to market? So those are, I think, some of the critical questions. A couple anecdotes I can offer. I think first, a lot of device knowledge is out there that hasn't been made public, unfortunately. And I think there are harms to that because a lot of the companies who own that IP aren't necessarily designing for most people in the world. And so then that means their technology, or the technology that can really save life, and if we recognize health as a basic human right, in some ways that becomes a barrier to that. On the other hand, one of the fortunate things is that there's a lot of intellectual property that's expired. And so one of the projects we're working on at Olin College within the Affordable Design Entrepreneurship Program is around an open source hearing testing device. And part of it has to do with being able to build off of technology that's been around for a long time, been proven really well to work for early hearing loss detection. And then in addition, thinking about anything new that we create, new IP that might be created through our collaboration with, in this case, our partner in Guatemala. How do we, make that something that anyone can access so that they can also build upon it? So to that end, we're also have written a letter of support for an NIH grant that's being considered right now, but which is around starting an open source community related to these sort of hearing technologies. But even so, we'll certainly face various hurdles at each point in terms of getting the investment to get the product ultimately to market, to be able to cut the tooling, to be able to get that all the way. One project I can also point to in which we were able to do that is Firefly Phototherapy. This is a device designed by Design That Matters in conjunction with MTTS Asia and a foundation called Thrive Networks working in Vietnam. In that case, we really had to talk about the issues around design for the majority world and essentially get different donors who are interested in investing in a lot of the research and development process, as well as even paying for some of the manufacturing tooling costs in order to get that product to market. And in that case, it's a radically redesigned phototherapy device. Phototherapy's existed for a long time, but this really takes a lot of the guesswork out of some of the adjustments and some of the parts that could easily break and puts that on the market. In that case, Design That Matters didn't pursue any patents or any IP protection, so anyone could potentially grab the device, tear it down, and mimic some of the aspects of the technology. But I think in that case, we didn't go all the way through to creating it a completely open source design available, and kind of waiting to see, are there sufficient people who want to create this from scratch, or are they happy building off what's available from MTTS, who also now has a manufacturer in Ghana. So it's a little bit of a spectrum, open source being important for democratization, but also options of something more or less than open source, in terms of the example of Firefly phototherapy. I hope that makes sense.
Yeah, it's a very complicated landscape, I think, and we do need to change that paradigm in order to make advancements in direction of democratization of healthcare. Yeah, so a question I'd like to ask Andres, we've been talking about multidisciplinarity, education, and there is, I think, there are models of interdisciplinary education. Do you have a vision of the future of multidisciplinary education or education in general? I mean, I know education is one of your strong interests.
Thank you, Arti. In the school from a couple of weeks ago that you were organizing in Italy for PhD students, we saw that healthcare technologies designed by biomedical engineers, of course, have an impact as medical doctors and well-trained medical professionals have an impact, but also it is on health, I mean. But it is also fundamental to have like good infrastructures, good water quality, food in general that can be cultivated and grown in safe and healthy conditions. And I think for this model of good health and well-being for all, many kinds of professionals should collaborate. So one of the models that, for example, in the world of design and architecture was especially impactful due to its multidisciplinarity 100 of years ago was the Bauhaus model, created by Walter Gropius and many great professionals who created a new way of training people, let's say, through highly holistic project-based learning. Let's say the students were students of architecture, constructing the whole campus, the livings for the professors, the livings for the houses for the own students, dealing with the infrastructures of the campus, designing afterwards the products in the workshops that were fundamental part of the training. So perhaps some of this idea of a biomedical Bauhaus could be for the 21st century something interesting, like putting together architects which will become experts in the hospitals of the future, putting together the civil engineers that will design and construct healthier cities, healthier rural or better connected also rural environments, biomedical engineers designing the health technologies of the future. Why not mechanical engineers dealing with the machines, turbines, pumps for pumping water, turbines for creating energy where it is needed. So like creating let's say, point of care universities, or something like that, that could vertebrate the future of engineering for health, let's say.
Yeah, that's quite a vision. You know, I think to put forward projects like that, I think it all boils down to funding, essentially. You know, like we need to have ideas, but also to have the opportunity to implement them. So I'd like to ask Victor, you know, what are the possibilities and constraints of funding this kind of educational project in Africa, or even in you know, in other countries? You seem to have your finger on the pulse in terms of funding at times.
Well, thank you very much. Well, I have a belief that funding is often not really the first thing that comes to mind. I think all the discussion we have had today, very few people ever said their main constraint was funding. And so, yes, so funding is important. I think we learned that from COVID-19. I think the bigger countries, of course, could easily outbid the poorer countries in the purchase of medical devices or personal protective equipment, with ventilators and things like that. So in a way, that is kind of one angle. But when it comes to education, well, it is a mixed bag. You have the countries, I think, like the Nordics and others, where the education is literally free, and therefore universities have been very they can easily experiment with different models and how they want, for example, to teach. So because almost every student doesn't pay all the way, I think maybe up to their bachelor's degree or something like that. Of course, the other flip side of that equation is you do not have a lot of private universities like you have in the US and others, because if you get the public sector funds or the entire education system, people just don't see how the private universities are going to survive. And so in some countries, we literally saw nationalization. And so that basically brings us to, in Africa, it is almost this, I think, a similar situation. In some countries, they're tinkering around with free education. And on the other side, others are thinking, I think, running away from the 1990s on how do you actually fund education, which is a problem. Then that brings us to how do we fund research? I think that's perhaps the biggest issue, given the issues we're talking about, designing medical devices and bringing new innovations to market. And so we are hoping that we can make good cases, which is something we learned from COVID-19. I think Daniel and I were recently in Addis Ababa together talking about the project we're calling Origin. And the South African gave an example about ventilators. They actually managed to get an ventilator to market into their hospitals very quickly. And so the question they were asking is it possible that we have platforms where we can raise good questions that attract both private and public funding? And so to spin it around is, how do we actually maybe propose new models of education that are more interesting for funding, to attract funding from both the private or the public sector, especially for research and development, which is largely our PhDs, our master's degree students, and things like that. And so perhaps that is something we all need to think about. There is a lot of goodwill in terms of money for education. I think over the last 10 years, we've seen more centers open up, called centers of excellence in universities funded by the World Bank. I think nowadays there is also an effort going on by UNDP. They want to raise $1 billion. I think for the center they want to build in Kigali to fund basically research around innovation and entrepreneurship on the continent. And of course, so medical engineering, given that we already can spend so much time building up the human capital base and entrepreneurship skills and mindset, should really be able to benefit on that. There is an effort also, for example, with UNDP on accelerators, which they are trying to build accelerators in all the countries, especially in the developing world. So there are a lot of areas that I think are funding around education. I think what is really important, I will be asking all of you after this is, what is it that the universities actually are doing? What are the cases that we can present to say, if you fund us over the next, I don't know, 5-10 years, we are going to achieve X, Y outcomes. Forget that. I'm not saying we achieve this impact. At least these outcomes will be there. And that's what politicians, for example, can hang their hats on. If they're going to campaign and you want to win an election, you need something you can tell people, if we're putting money in education, when we are done, they will have jobs or they'll run businesses, they'll create what? The thing that they want their children to be. So in a way, I think that's a question perhaps I'll leave with you. I think as far as otherwise, there is more goodwill today than I think than there was perhaps 20 years ago, especially in Africa. I think very few people were ever wanting to fund anything in higher education, especially. Thank you.
Okay, yeah, that's a challenge. So you've thrown that. Yeah, thrown the gauntlet. Something that we need to work on together. Yeah, so what I'd like to do now is, before we close up, is to ask the audience if they have any questions, if they want to know more about what we're doing and know more, find out more about the possibility of open source collaborative design in education. Are there any questions from the audience? You can raise your hand or unmute yourselves. Okay. All right, I cannot see any, but if you would like to contact any of us, just drop us a line on the chat of this particular session, and we'll be happy to answer your questions and discuss ways of going forward and collaborating towards the goal of democratization and achieving the Sustainable Development Goals. So thank you very much, everybody. Thank you to our speakers for giving your time. For a lot of us, it's quite late at night, and so I really appreciate your willingness to be here and to discuss your experiences and share your thoughts with everybody. So the session will be available online as well. So if you'd like to spread it around, let people know about it. There were a lot of people who had signed up, but perhaps they couldn't make it because of time differences. But yes, thank you very much again for attending. Carmelo has shared his email with you, so you can certainly contact him or contact whoever will provide their emails. We'll write them down now before we sign off. And yeah, good night to everybody, and thank you very much for joining us.
Thank you, and good night.
Good night.
Bye.
Good night.
Thank you. Good night.
Bye-bye.
Bye.
Bye.
Bye, Andres.